So this is one of my little ones. This was the good picture. So Mom thought he'd actually died, and so the picture, she took two pictures, one of him face down in the crib when she found him that morning, and this is what he looks like sitting up while she's calling and saying, we gotta come into the clinic. So this is one of my actual little guys, and he's, I don't know, he's about 10 months old, little kid. And it happened to be a family I already knew about, which made it much easier, but this would not be uncommon for what you'd actually see. And so if you're seeing a kid like this, and people are coming and saying, oh my gosh, what's happened, there are lots of things you need to go through that are real basic. And your basic things are always your history, because a lot of things you can't get with lab, or you can't get reliably with lab, and the most important thing in the bleeding disorders is the history. So you've got the patient in front of you, what's their personal history? Are they old enough to have had any hemostatic challenges? And I promise we're going to take a break, and do ask questions if things come to you, because I'll lose track of it otherwise. What occasions have they had where they might have had bleeding besides the current episode they're presenting with? How significant were those? Getting laryngotomy tubes is different than having a tonsillectomy, obviously in the severity of the defect. And so if a kid bled with laryngotomy tubes and didn't bleed with tonsillectomy, you're like, right. Because certainly the tonsillectomy should be a larger insult to the coagulation system. Gender. Women have hormones go up and down, men are pretty much what they are. But then also, we'll get to that, and that's important, that'll be important on when you do your testing as well. Men also tend to be more involved in more hard impact activities. So it tends to be my 2-year-old boys who are jumping off the sofa more than my 2-year-old girls. It just is. They tend to be more involved in football than the girls, although the girls are doing cheer or gymnastics, are also high impact hard surface kind of sports. Where are the symptoms presenting? Is it mucosal? Is it soft tissue? Is it deep? And you've got to distinguish, and you've got to ask about all of them, because adding them up will make a difference in what you test for and what you do with those results. Soft tissue ranges from, is it bruising? What's the biggest bruise you've ever had? Was it lumpy or just a color? How long did it stay? And was it in proportion to the injury? I fell out of a tree and I had a bruise for 3 weeks. I would have a bruise for 3 weeks. Or nothing happened and I had a bruise for 3 weeks. And it was lumpy. What was it? Or was it a muscle bleed? Couldn't move the limb, swollen, compartment syndrome, quite a different category. Was it soft tissue? I had a tooth pulled, I bit my tongue. You got to kind of characterize where it was and go from there. And there again, who in the family? And you need to go through the family tree. You can't ask anybody in the family bleed. You're going to have to be specific. And you've got to do both sides of the family. Because if you don't know what you think you're looking at, and common things are common, you can't just assume, oh, this is going to be sexually inherited, and I need to ask about mom. You really do need to ask on both sides. And you need to go through pretty specifically. Excessive bleeding with procedures. What procedures? After childbirth, history of anemia, unusual or persistent injuries after sports, unusual death after a routine procedure. Most people don't bleed to death after knee surgery. That would be significant. Most people don't get hospitalized for a week with a nosebleed. I mean, those are significant things. You got to kind of pull it out. Was it grandma on which side? And did the parent of the child have relatives? What are the siblings' histories? What are the parent? You've got to follow it back, and then you can start to put things together in terms of what's the inheritance pattern that might guide you towards the testing that you draw and the analysis of it when you get it back. What is their ethnicity? Some things are more common in certain populations. You need to know that as well. And figuring out, like I say, what this child or this adult's pattern is. It's not uncommon that we'll diagnose a grandparent after we diagnose a child, because everyone's willing to bring a child in to get them stuck, but adults are very reluctant to show up and have their lab drawn. So you do things in reverse order. And then you got to figure out, okay, let's characterize what's the type of bleeding the patient actually had. So in my little guy, we had blood all over, and so you've got to actually get a hold of the child and say, which part of your body's bleeding? Did you bite your tongue? In this case, he actually did tear the frenulum. It's usually the upper frenulum. It's more common at this little age where they're falling forward, pacifier in the mouth, bottle in the mouth, anything in the mouth, and they go like this. If they've got a pacifier in their mouth and get smacked, that's what's going to go. Sometimes that'll be a child abuse issue, but it's usually the upper frenulum. Is it a tooth that got knocked out? Got to look at it. If they're saying, oh, they've got bruising, okay, get them to tell you what's a bruise. Are we talking polka dot spots? Are we talking petechiae? Can you feel it? Does it have a hematoma? Is the hematoma hard? Or is it hard with a jelly area? Is it soft in the middle or hard in the circle? How to get them to characterize it. A lot of times I want to tell you, oh, and I know it was old because it was already yellow. Okay, well, they don't always go in a normal progression. You can't look at a bruise and tell, oh, this must be 4 days old. Doesn't work like that. You've got to get them to tell you. Where exactly on the body are they having it? Is it impact surfaces on the front of the body? Is it the back of the body? Based on the age of the patient, are those reasonable places? What was a likely type of trauma to have experienced that? So in my neck of the woods, bruising and hematomas are pretty common. So we were going to have an academic lecture for grand rounds, and so the doctor, because we always said, our impression is this is what they have. He actually did a literary search of a primary care clinic, children who came in, and assessment of bruising. Children were most likely to have bruises on forehead, fronts of the knees, shins, ulnar surfaces of the forearms. Most common. Not the only place, but most common, 90% that accounted for things. Truly, if they had siblings, higher number of bruises. And I've been saying that for years, but academically it actually proved it. So that's where you expect, and there again it's developmental. So a 2-month-old who can't do anything at all except flop their head may, especially if they're prone to bleeding, have bruising front, back, from flopping their head on your collarbone, your chin. In the bleeding disorder community, I've seen zippers, brads, fingerprints on ribs. Well, you think about it, it's bony surfaces, this is your least padded area, you're picking them up. As they're a little bit older, bony surfaces, the front of the pelvis, ribs from leaning over. Occasionally from car seat buckles, especially if you pinch them when you're putting in the bottom. As they're old enough to get hands or legs stuck in between the bars of the crib. Well, that's pretty much it at that age. If you do a heel stick, or they'll come out of their discharge and they've had IVs when try to start in their hand, that would not be an unusual place, and you got to kind of watch it and see. But little ones are not going to have joint bleeds because they're not doing anything. Once they start on their knees, yes, you're going to see the crawlers who've got repeated hematomas. They keep every child who's learning to walk is going to have at least bruising, if not hematomas, along the shins, forearms. That's where you expect. As they're standing up, they'll land on their butt. Remember, the points of the pelvis are sharp. You land on your Legos, you land on your butt repeatedly. You can have a little bit of a bruise on the butt, or you can land on a good toy. Or some grandparent thinks that you need to be on a hobby horse because they had a wooden horse when they were a kid. There is no padding in the groin area, and you can get bruising there. Everything's got to be reasonable. Little old people have bruising in their contact areas, right? They do. They've got leaky blood vessels. That would be expected. Sometimes you'll see things on the back of the leg from hooking their legs behind a hard seat, the edge of the seat, or hooking their ankles into the back of a chair. Most people are kind of unpadded on their spine, so you're sitting in a hard chair on the spine, rubbing it back and forth. You may have little polka dots up and down the rigid spine. Those are not uncommon. Those are pressure points you could expect to see. All right, child abuse happens at any age, no elder abuse, but those are reasonable places. It would not be unusual to see bruising or hematomas, but is it in proportion to what the activity you would have expected? So kind of identify it. If you know there was an injury, when did the bruising appear in relation to the injury? Did it reappear several days later? You thought it was getting better, and magically reappear, often worse the next time, when it kind of looks at that sort of history. And you had a tooth pull. Did it bleed immediately in the dentist office? Was it the next day? Was it 3 or 4 days later? You had a surgical wound. There again, when did you start to have problems with it? Sometimes they'll tell you you had a laparoscopy and had bruising that showed up 5 to 7 days later. And there again, remember, blood travels by gravity. So if you've got a laparoscopic injury, the bruising may actually come into the inguinal creases. If you had a soccer kick to the calf, quite common, the bruising may show up in the ankle. If it's not a new bleed, that's just migration of the echymosis. So, where did it occur? And get them to try and fill in the data for you. What are they taking? Everything counts. Anything that goes in their mouth. In the old days, I used to have grandparents who went to use a heavy colloidal paste they would put on the kids. Heavy metals are never a good idea. Anything at all they're taking. Prescription meds, over-the-counter, Monster drinks, 5 hours, anything at all they're taking. You laugh, it's not funny. It had some great blood pressure and kidney issues with people who just thought, I just need to have. Over-the-counters, your herbals, what's in it may not be what's on the label. So it's quite common to have a contaminant in there. And people don't always think, oh, I'm just taking, sal palmetto, I'm just taking something for my cramps, and this is supposed to be herbal and it's fine. Anything that's good for circulation, anything that's good for cramps, I can guarantee you it's going to affect the platelets. You need to know everything they're taking, all the medications they're taking. You need to know if they're taking something for diarrhea, is it Pepto-Bismol? Is it Creamulsion? You need to know what they're actually swallowing. Everything counts. And it may not have been what they're taking today, it may have been what they took last week. Did you just finish antibiotics? Everything you're taking. Recent illnesses. Recent viral illnesses particularly. Viral illnesses definitely have sequelae when it comes to the coagulation system. Anything ongoing, chronic kidney issues, liver issues, family history of liver issues, ask. Anticoagulants are fairly rare, but there again, after a viral illness, weird things happen, never had history before. You've got a 45-year-old who comes in, we're having problems bleeding, you had a knee replacement 3 weeks ago, but they're bruising other places, weird things can happen. Pregnant people develop antibodies, pregnancy is an immune stimulus, they will do weird things, get a good history. And there again, they may be 45 or blood before, that's significant. They've had their appendix out, they have their gallbladder out, and now they're bleeding. You need to give it a good shot. Vitamin K deficiency we'll talk about more. It's rare. Some people, they think they're bruising, they'll go get some vitamin K. They're taking it early, they think it's a good idea. Just ask. They don't know what they're doing, but it'll mess up your results. And liver disease. Liver disease, hepatitis C is more common now. We're aware of it. People will report that, or they've had things in the past. We're getting a lot of fatty liver, just from general obesity. When you mess up tissue, it doesn't produce its normal clotting factors, things for different stuff. Ask. The exam. So you ought to do the history first, so you know what you think you want to look for, and then actually put hands on the patients. And you got to touch them. You're going to have to touch them. And it's pretty basic. It's not uncommon that you'll see people with scratches and blood in their ears because we're addicted to Q-tips because our ears itch from the allergies. They just do. But you're looking, do we have bruising inside the mouth where they've bitten their cheek? Do we have persistent oozing from gum disease? Or do they just ooze from their gums otherwise? If they got any good reason, do we have obvious gum disease, or are we just oozing wherever? Do you have any adenopathy? Do we have any evidence of recent infections? Are you seeing odd little bruises they may not be aware of? No one sees the ones on their back unless someone's told them that they're there. Pretty common situations. You'll see the spider angiomas. If you've got liver disease, sometimes you'll see those changes. You may be able to palpate the liver with a deeper inspiration, or sooner, which would certainly be one of your areas of concern. Look and see what their scars look like. Their scars unusual in character in terms of collagen vascular reactive issues. Look at their prone areas. Feel, some people are well padded, you may not see hematomas, but you can feel them. And anything that you think you see a bruise, you need to palpate and see if you've got a hematoma, what's the character of that underneath. They're complaining where they've got, warm swelling in their knees, whatever, you need to do both a seated and supine exam and look for effusions, what's the character of that foggy, soft heat. Anything that feels weird, again, check for temperature. Is it a septic area if you've got cellulitis? They'll have to give you the history of hematuria. Stones, history of stones is always important, or history of infections. Mineralogy we're going to talk about at the end quite a bit if we can, because that'll be good wherever you're practicing. Arthritis, everybody's got a different definition of arthritis. You need to know which joints are involved. Are they symmetrical? Does it come and go? Is it morning? Is it night? Is it with activity? Is it 5 days a week? Or is it 7 days a week? Activities are different from weekends to weekdays. And then your general neuro exams. Part of that is, we had a week in the past where we had some asymmetry, as well as documenting now what they look like before things happen. What to draw. One of the things my wonderful old physicians say is, if you don't want you to know what the answer is, don't draw the test. If you do a shotgun approach, you're going to get some weird things, and then you're stuck having to follow them up. So you need to think ahead with what you want to draw. Chances are that you're not going to get an answer from the first draw, but that's normal, and that's appropriate. So check for the most common situation first and evaluate baselines. Do we have platelets? What's the number? Are we anemic? Is it iron deficiency? Is the white count elevated? Do some basic things first before you say, oh gosh, I think I want to draw a factor 10. Yes, a factor 10, something. Start with the basics, okay? Before you go getting fancy stuff. Some of the stuff can only be drawn at a reference lab. And you won't be able to get it paid for unless you've got a code to explain why you're drawing it. You just can't say a history of bruising and go order a factor 10. I mean, they're not going to get paid for it. You've got to use your brain. The other thing we'll try and do is, if you have tenuous venous access and you've got a lab that will speak to you, is to draw your basics. In this case, we'll get in a CVC and a coag, probably PT, PTT to start with, save the extra plasma. On little guys, you're lucky to get what you can get. And we'll go from there. If you have to chase the child around the room to get their blood pressure, and it takes 4 people to hold them down to stick them 4 times to get blood, some of those responses you're going to get from those labs are going to be affected by the activity and the trauma obtained the specimen. Everything went the right salt. Some of them you'll need to draw in an empty stomach or low-fat morning, but CBC, PT, PTT, you're going to be golden. And then you go from there as you get smarter. Okay. I know you've seen these. You've seen this. You ever see the black and white cartoon of this one? They all look the same. I've been at academics for a long time. So when I explain it to my patients and we take them to camp, well, you got to think they're crazy when you take 91 kids with bleeding disorders to camp. Anyway, so we take the kids to camp. But we also do the education for the family. So this is what I use, and this is the best idea I've come with in a long time. This is the salad bowl of clotting. Okay? You will remember this wherever you practice. Okay? I promise you this will. All right, so. In your blood, on an average day, yep, see, it's already leaking. You have everything in your bloodstream that you need to make a clot. Everything you need is already there, right? It's just floating around, minding its own business, waiting for something to happen. Okay, and for the sake of the argument, we're going to say that you've either nicked your knee or you've nicked your chin shaving. Okay, you've made a defect in the integrity of the skin. You have pulled apart or cut apart some blood vessels, right? So the first thing the vessels are going to do are try and constrict, right? A couple ways to help that happen. One is use your thumb or whatever you need to do to apply pressure to those blood vessels to stick them together, right? Torn endothelial will stick together, the blood vessels automatically want to constrict, that's what they do, right? Hold pressure. Our joke is, it's always 5 minutes, right? Give it a chance to actually work, right? And then because you have torn endothelium, there are chemicals that are released from the torn tissues itself, which activate some of the clotting factors. So your happy platelets, which in a natural state are just floating down the bloodstream, minding their own business in the presence of torn endothelium, will start to come together and stick to the torn endothelium. And their response will be to start to stick out their little pseudopods. Right. And so they're passing by, they're noticing, there's torn endothelium, they are sticking together. Oh, there are other platelets, and platelets like to, join together. You see one platelet, and here come the rest of them because they all want to be in the same place, right? Platelets would tend to aggregate themselves. If it is a minor defect in the vascular system, the platelets alone will make a mesh that will last for about 4 hours. And if it's a minor injury, that's all you need. But at the end of 4 hours, your body thinks it's all healed, and they will disperse, they will break down and go on. Okay? If you really got yourself, though, corner of the chin, corner of the knee, you got a good gouge, it's going to take more than platelets. And at this point, there's more endothelium torn, there are more chemicals being released, and your von Willebrand's factor, which is floating around all the time in your blood vessels, is going to start, it's received the chemical messages, and it's going to start drawing in its job. So, von Willebrand's factor is a fairly complicated protein. We'll talk about this later in this morning. It has 3 basic functions. One is it adheres to platelets, it adheres to factor VIII, and it also secretes additional chemicals which enhance clotting. Right? So your von Willebrand's is going to get involved, and it's bringing more of its friends, factor VIII, the big protein, into the system. Factor VIII is only bioavailable when attached to von Willebrand's factor, which is going to be an issue we'll discuss shortly. And that starts to build factor VIII, activates factor IX. Here we go, factor IX. It's coming along, and then you're proceeding through the clotting factor. Yep, see, they're leaking all over the place. And your other things proceed through the intrinsic and extrinsic. Right, so you make a nice clot, and at the end of the day, when you've gotten the clotting cascade activated, you're going through, the last step is that you will form a fibrin net over the top. Fibrin's very critical at the top of the net. Okay. 3 to 5 days later, primary healing, post-op, primary healing 3 to 5 days, post-op, your body will lyse, fibrinolysis, this clot. Okay? So this peels off. Really good clot. Okay, and would begin to degrade the products. If this was a large defect, if you didn't have enough platelets, if the platelets didn't adhere, you didn't have enough von Willebrand's factor, von Willebrand's factor was not functioning properly to either recruit platelets, it didn't attach properly to factor VIII, which then was not available to attach to factor IX, you didn't have enough factor VIII endogenous, you didn't have enough factor IX, you didn't make a stable clot, even though the fibrin was formed, the area may start to re-bleed late because it never healed completely the first time. So this is why you've got to find out, when did the bleeding occur with respect to the injury? Did it recur without further injury or minimal injury? If you had surgery, was it bleeding immediate or later? And then what was the characteristic of it afterwards? That's why. We're going to come back to fibrin. If we have time, and hopefully we will, we need to take some time to do good practical information on evaluation and treatment of menorrhagia and nosebleeds. Since you just did ORL, we'll be interested to hear what they said and what I say. Okay, so the clot. All right, so that's the visual way of how things work. If you are missing one of the components, it will affect your lab work. So if you have a mild deficiency of one of your clotting factors, it will take a larger insult to the hemostatic system before you're going to have any symptoms. And the lab changes will be smaller. So if I have someone who has 0 factor VIII, their PTT may be over 120. But if they are just mildly deficient, 20–30%, the PTT may be borderline normal. So everything with a grain of salt. And so if your history outweighs what the lab is showing you, it may be the lab that's there and not the history. So everything with a grain of salt. Okay, so, well, all right, so your PT and PTT are kind of your gold standard. You can screw up how you draw the lab. So if you have to fight a patient to get the lab, if you have to stab 4 or 5 times to get the specimen, if it's a drip and ooze collection, you're activating the tissue factor in that lab draw, and your results may not be that. Just be aware. Okay, so the quality of the specimen makes a difference. PT is testing your intrinsic system in the common pathway. There are a lot of things that can mess it up. One abnormality alone is not enough to make a diagnosis. So this is your screening lab, this is not your answer lab. It is relatively uncommon for the PT to be prolonged. So it's a lot easier to mess up the specimen than the likelihood that you actually have someone with a truly long PT. But it happens. Depending on where you're practicing, you may see this. What's more common is that you've got a prolonged PTT. And there again, there are a lot of things that will make this inaccurate. Okay. And in the old days, and still some places, they will do a pre-op screening, PT-PTT, the morning of a morning procedure, and they'll get a result back that's borderline and say, oh, it's probably just lab error, we're going to go ahead and do the procedure, without having done an adequate history ahead of time, and sometimes bad things happen. So smart people will do a pre-op screening a week or so ahead, so that if you get a normal results back, you can either repeat the results or realize that you need to do some further investigation before you just hope to goodness that that was a lab error. Okay. But there are some things that will make it abnormal. For the most part, you cannot closely correlate the severity of the lab abnormality with the severity of the bleeding disorder. It's not that good. So the farther up the clotting cascade the abnormality is, the less likely it is to affect your PT-PTT. Use your history. Okay, so prevalence. And this is where your money is, and this is why you don't want to use the gunshot approach. Common things are common. Technically, autosomal dominance, incomplete penetration. You've done genetics, people remember your genetics. People know in your family, somebody had red hair 4 generations back, how does it show up now? Doesn't make sense. No one in the family has curly hair except this one kid had incomplete trend. Autosomal dominant, incomplete penetrance, really, really common. Von Willebrand disease, depending on how you use the diagnostic criterion, 1 to 3% of the general population. Young ladies, we're not talking old women, young ladies who come in complaining of menorrhagia, and we quantify that, and like I said, I'd like to spend some time on that at the end. Chances are more like 20%. Age matters. Platelet dysfunction, a little bit higher than von Willebrand's in African Americans. Maybe 1 to 3%. Okay. So it's common, it's particularly hard to test for, but you've got to use your indices of suspicion. 5, 10, and 11, very uncommon. You're getting a lot of noise now with people saying, oh, I'm factor V deficient. Okay. Somebody in their family got diagnosed with factor V light because somebody had a DVT and got worked up for clotting. They are not factor V deficient. That's everything with a grain of salt. Factor 13, technically 1 in a couple million. I've had 2. I got a real factor 1. Factor 2s are real rare. Factor 7 is about 1 in 500 to 1,000, but I'm seeing a lot of mild deficiencies will mess up your PT, but clinically they don't have much wrong with it. So there again, you may have abnormal coag results, but the person doesn't bleed, which is one more reason, don't draw it if you don't know what to do with the results. Okay, sex-linked, this is where your movies are made out of. Hemophilia A, 1 in 5,000 males. Factor IX, hemophilia B, Christmas disease, 1 in 20,000 males. Most males have a mother, and about half of the males have a female sibling. So for each of these sex-linked disorders, there's probably a woman who is a carrier. And we'll talk about this in some more detail. Those carriers may be symptomatic to the point of having levels of 0. And that's new from your printed literature, because there again, unless you check, you don't realize. And women may not complain as much about symptoms when they're, yes?
Oh, I had a question on the autosomal dominance.
Yep.
With incomplete penetrance.
Yes.
Does everyone get the disease with a variant, or?
No. Right, so in the old days, 4 years ago, 4 years ago, there was no such thing as a carrier state in von Willebrand's, now known to be a lie, yeah, because of incomplete penetrance. And the other issue with particularly factor VIII and von Willebrand's factor is the levels will be about 15 to 20% lower in blood type O. And they'll bleed better than those levels. ABs have the highest factor level in the O. So when you're getting history, blood type is also important. Yeah. So we're going to talk about von Willebrand's for a while. We'll talk about incomplete penetrance because it makes your history very important, and diagnosis can be very difficult. Yeah, we'll talk about that. Okay, so looking at this beautiful diagram, is this autosomal or is this sex-linked? And unfortunately, if you look at the names, it will come to you. This is sex-linked, yeah. So this is the royal family tree of hemophilia, Prince Albert, Queen Victoria, the Tsarina of Russia, little Alexander, Nicholas and Alexandra. And they turned out to have factor IX deficiency. It's hard to get appropriate genetic material to do that, but they finally figured out it is factor IX deficiency. Yes, the royal disease. Right, so 1 in 5,000 males. There's no ethnic predisposition. And royal people now are not more like anyone else. But yeah, so this would be the same for factor VIII or factor IX in terms of inheritance. Right. Okay, so, love it. Yes! All right, even better. So I wish I had a patient to show you, but we'll manage with this. So, for the purposes of today's talk, this is a normal knee. So you have your landmarks, and I don't like doing knee exams with an extension, but I will if I have to. I'd much rather do it flex because you can actually get the fluid better. So you've got a patella, yes?
The laser doesn't work.
On our end, at least.
Well, shucks to goodness. Okay.
Just in case you're pointing out anything important.
Okay, thank you. Okay. But I can do it on yours. Okay, let's do it backwards. Okay.
No, you.
It
doesn't.
show up on the screen.
Yeah, forget it. Okay. Take my word for it. All right, we'll use my knobby knees. Okay, so the patella is midline. Let's see. Patellar ligamentous laxity is an inherited trait. In my general impression, it seems to me like more of my mother's have it than my father's, but anyway. See a lot of that in my population. Anyway, so you've got a knobby knee, you can find your landmarks, right? You may have, the older you get, you go a little more of it, you may have a little bit of fluid within the bursa sacs, right? You've got some fluid within the synovial lining that you can percuss and ballot back and forth. But you shouldn't lose your landmarks like you do in the second form. So you can't really tell where the patella is in the second leg, right? And there is some fullness that obscures the femoral condyles. So it's kind of wide. If you laid your hand on it, and it were a fresh effusion, it would be warm. It would be warmer on the side that had more fluid. If it's fresh, it would be squishy, not quite palatable, but squishy. If it's been there a while and it's actually due to synovial hyperplasia, it'll be boggy, like squeezing Jell-O or mashed potato. Yeah, but it's a late finding. So if someone actually has a joint bleed, they can feel it before any test in the world can demonstrate that there's a bleed. So for patients with severe hemophilia, for example, we'll say they need to treat at the first instance of symptoms. And what they'll describe is there's a stinging, there's a burning, there's ants crawling, I can feel the pressure, and then subsequently they'll develop localized effusion, warmth, pain will get worse, they'll lose motion. So that's pretty standard for me. Yes, okay. So these are advanced findings. Have you done any radiology yet? Okay, good. All right, so in A, what's wrong with that film? Yep. Okay, how's the joint space?
Not one.
Right, so initially with a fresh bleed on a relatively undamaged joint, when you have an effusion, the joint space will be widened because of the pressure. But over time, they'll actually lose joint space and begin to have cartilage as well as bony changes, and eventually you'll start to see erosions. And then as we look in B, it's basically trying to fuse itself together, so it gets to be a sandpaper kind of an issue. If we had a nicer photo, you would see that the patella is usually lateral, the femoral condyles will overgrow. You get all sorts of anatomy that you were trying to figure out what incarnation of the creature they used to be with old disease. And so they'll complain of a lot of pain, and that's true, but it can be very difficult to kind of analyze what happened because it's not the acute situation that's going on. This has been going on for years and years and years. So A might be after, I don't know, 5 years of repeated bleeds, and B is this has been going on for 10 years or longer. Yeah, these are not new findings. Okay. Very good. Let's go back and we'll pretend to do this one more time. Okay. In factor 8 and factor 9 deficiency, the most common sites of significant bleeding are in the joints and muscles. And this is going to distinguish it from platelets and von Willebrand disease, which are more mucosal. The same way you're taking history, you need to account for the patient's age, the location in which people are going to have, children are going to have bleeds depending on their age. So an infant with a bleeding disorder will have bleeding at the site of trauma. That includes vaccines. So they can be soft tissue or muscular, depending on how fat that child is and how deeply the vaccine was placed. They still give IM vaccines, but sometimes you hit a blood vessel and sometimes you don't. Children with von Willebrand's and hemophilia will have extensive hematomas over the shins, forearms, and these will be re-injured, so when you examine them, you've got fresh, soft, squishy, as well as hard, resolving hematomas in the same general area. So multiple sites of trauma in the same location. As they get older, start to stand up, laying back on their bottoms. Hematomas, which you may or may not be able to feel. But any kid who won't sit straight, he's cocking up, or he's crying every time you're doing a diaper change. We're presuming to have a buttock hematoma. A kid who can't sit up and pull up is not going to get a buttock bleed unless you drop him or you whack him. It's not going to happen. The hematomas that we tend to get are generally round, kind of like a golf ball, because it's the point of the ileum against the hard surface. Little boys, but not my little girls, about the age of 1.5 years to 2, want to climb onto things and jump off. It's a developmental milestone. It's just what they do. And when children climb onto things and land, it's either head first or feet first. So if you're landing feet first, you're drawing the ankle. And the ankle will be the first site of a joint bleed in a child with a factor deficiency. They really don't seem to get much by way of wrist. There will be some elbow bleeds. And so what we'll get, and it's veterinary medicine at that age, is a child who was starting to walk or climb is now crawling again because they don't want to put weight on that joint. Or they will now have a limp and the foot will be usually everted to widen the joint space. It may be a problem to get the shoe on. Okay. So that's me different, and they may stop jumping. Children have a very high pain tolerance, so activity alone is not an indication of the severity. Symptoms on any child are always worse at night. Fever, earache, stomachache, everything is worse at night than it is during the day when the TV's on and the toys play with. Always. As they get older, we start riding a bicycle, we're trying on a skateboard, we'll start to get knee bleeds. It's not usually until we get in teenage years that I'm having hip bleeds. Muscle bleeds. Okay. The other great bleed that we can get, it's unusual but happens in von Willebrand's. Von Willebrand patients can have joint bleeds with enough impact. And since they tend to have milder symptoms, may be more involved in high impact sports than other people who need to be careful because they have a severe bleed disorder. So the iliopsoas muscle connects from the back of the pelvis, comes inside the pelvis to raise the hip. Between the iliopsoas muscle and the bony surface is your femoral nerve. So hemophiliacs are creatures of habit, and so sometimes they'll say, yeah, yep, the knee is swollen and I have a bruise and it hurts, it must be a bleed. Anyway, but because their pain threshold is so high, they're like, yeah, it's not that bad, I can still walk, you know that? Okay. But they don't always comprehend that if something hurts and there's not a bruise, swelling, or it could be a bleed. And so our teenagers, particularly, and my adults, will have an iliopsoas bleed. There are a couple ways to get iliopsoas bleeds. So if you've got someone in a flex position, exerting force, and this can be tug of war, shutting, moving furniture. Best one was moving a manhole, or they were trying to get a stump out. So force, flex. The other way we'll come and see in teenagers is having sex. We do have ways to help them do that without having, anyway, so flex and force, you can have a bleed. And so there's this vague ache in the back, muscle insertion. The extension is going to be reduced, so instead of a full normal extension, the hip is maintained flexed, hurts to straighten, so they flex to shorten the muscle, and they are weak and may have some numb and tingless on the front of the hip, not lateral front. And so the questions are, can you lift your foot to get your pants on? No, I throw them down. Or can you lift your foot to get in the vehicle? No, bad sign. So you're trying to identify femoral nerve compression with that. And it's one of those silent bleeds, but it's a really good place to form a pseudotumor. My guy who did the manhole cover finally came into the hospital 2 weeks later with the hemoglobin. It was about 5. Because it couldn't be a bleed because it was just back pain. But when he started fainting when he tried to get to the bathroom, he finally got in the hospital. So weird things that will happen. People with severe bleeding disorders, yes, can have bleeds in their heads. They are not generally spontaneous. It's generally after something. Kid falls out of a swing. New England Journal, of course, had the report about someone who had a spontaneous CNS hemorrhage after riding the roller coaster. We'll probably see more of those. You know, if you're going 60 miles an hour and then you stop, it's shaken baby 60 years later, right? Their little blood vessels, and especially as, you know, adults are taking aspirin for their heart and whatever else, we can reasonably expect those things to happen. But there's usually some sort of history. There's a rumor that people with hemophilia don't, you know, they have spontaneous bleeds. They don't have spontaneous bleeds. They have bleeds in places that get daily trauma. No one notices daily trauma. Okay, so they don't naturally get a hip bleed at the age of 6 months. That would be spontaneous, that's not what happened. So things with normal everyday traumas where we'll have issues. The other situations that bleeding disorder patients will have very impressive bleeds is GI tract. So if you've got the stomach flu, if you're vomiting repeatedly, you get a Mallory Weiss tear. For you and I, that might be a little bit of blood-tinged emesis, and for someone with a bleeding disorder, that's bleeding out. Or if they've got an ulcer from taking too much ibuprofen for their arthritis, GI bleed. And you'll see that quite often. Those are the most frequent things that you will see. Let's take a 10-minute break, and afterwards we'll do von Willebrand's and weird platelet stuff, and then let's try and talk about periods and nosebleeds. Okay, you're loose, 10 minutes.